Hello, my name's Rasha Al-Lamee. I'm based at Imperial College London and I'm one of the deputy editors at JACC. It's my absolute pleasure today to be joined by a longtime friend, Tom Johnson, who's an associate professor at the University of Bristol. And Tom, it's been a great pleasure over the last few weeks to be working with you as we've accepted your manuscript, the VFR analysis from ILUMIEN-IV at JACC, and of course you'll be presenting this at a late breaker at EuroPCR. So Tom, maybe you could talk to us about what the main question was that you wanted to ask as you did this analysis, and then maybe talk us through how you did it, how you went about answering that question.
Sure, and thanks, Rasha, and thanks to JACC for this opportunity. So this was a sub-study of the ILUMIEN-IV trial, which obviously was comparing OCT versus angio-guided PCI. And image guidance has now taken a much larger priority with 1A recommendations both for chronic coronary syndrome and acute coronary syndrome in the recent ACC/AHA guideline. But actually, we're still challenged as an interventional community to obtain the best possible acute results to achieve long-term patient outcome. And so what ILUMIEN-IV has provided really quite uniquely, from the fact that both the angio and the OCT guided populations had final OCT runs, is an assessment of the acute result by imaging. And really, as a community, we're still searching for the best metrics to guide us in how to be confident in achieving the best result. And so this analysis is really looking at a novel method of assessing stent optimization. So with this new metric of virtual flow reserve, VFR.
And Tom, so maybe, I mean, obviously this is it's a kind of relatively novel method. It was described by Alan Jeremias and others most recently. It's something very new to us, but what did you find?
Yeah, so in really assessing a cohort of ILUMIEN-IV, a very large population of all of those who underwent single vessel stenting, we undertook a retrospective quantification of VFR on the final OCT run, and we're both able to look at a comparison between the angio and OCT guided groups, where we've seen a difference with a better VFR in the OCT guided group. But then most important, really trying to understand how VFR might assist us in predicting subsequent target vessel failure, target lesion failure. And I think what's exciting from this analysis is that, along with the previous work that's been done, which has identified particularly minimal stent area, MSA, as a predictor of subsequent events, VFR seems to be synergistic, so additive to the MSA value, the cutoff that's been identified at 4.5 millimeters squared. But we actually see that VFR performs in addition to MSA in terms of predicting future events. So it may well be that this ability for us to assess the vessel in the acute phase may offer the interventionist an opportunity to make change prior to the patient leaving the cath lab.
Thanks, Tom. And so maybe could you answer the argument that people might make that, well, VFR might just tell you about diffuse disease that I can't do much about. Why is it helpful to me? That thing that people say often, I don't want to find out about physiology at the end. It's never ideal and I don't know what to do with it. What would you say to them?
So I think then we have to recognize the limitations of this analysis. And so this is retrospective. It's really kind of hypothesis generating in terms of determining the ability for VFR to guide us. But we are only making an assessment post-PCI. And actually the real excitement would be the combination of the anatomical value that the imaging provides alongside potentially a physiological or surrogate physiological assessment made at the point of decision making for the stenting, so in the pre-PCI phase. And so we, as you mentioned, Alan Jeremias and the Fusion study demonstrated the comparison of VFR against invasive physiology. But really, the next step is about utilizing VFR holistically from the beginning to the end of a procedure. So both determining where we should be stenting? Should we be stenting? And then once we have stented, using this VFR metric to then identify whether we've done a good job. So I think for the moment, we are defining VFR as potentially a useful metric, but we haven't used it as you would prospectively from the beginning to the end of a procedure.
Thanks, Tom. And what do you think in terms of, the comparison with a wire? What does this technology potentially have in terms of its pros and what might be its cons?
Well, I think we have to reflect on really what's happening out in the real world. So these randomized trials don't reflect standard practice, and actually imaging penetrance and invasive physiology penetrance is relatively limited globally. And often the barriers that are kind of mooted as being the reasons for a failure of adoption are predominantly time and cost. I think education is also key, but if we reflect on time and cost, then actually having the ability to maybe gain physiological assessment upfront, but the anatomical and physiological benefit by combining this information may limit some of the expense, and then actually may accelerate our decision making in the cath lab. So the hope would be that as people come to adopt technologies more, that actually we can offer more in terms of the outputs. I think the educational challenge is that one of the barriers to the adoption is that there are metrics that are difficult to interpret and to respond to. And so having another assessment like VFR, which may give you maybe not a dichotomous value of good and bad, but giving you some understanding of whether you've done as good a job as you could hope, is going to assist us in more confidently achieving the result that we think is going to provide the patient with long-term benefit.
Thanks, Tom. And maybe you brought up dichotomy. One of the things I liked about your analysis is there was a real attempt to think about this as a continuum. And what would you say is the advice out there? Is it okay to be using, post-PCI binary cut points? Should we be looking at this as a continuum? How do we do it in clinical practice?
Yeah, well, that spans a lot. So thinking about both of kind of physiology and then the imaging. I mentioned MSA cut point of 4.5, and that's become very kind of well acknowledged. But there's a real danger there because that's entirely dependent on the size of your vessel. And I think what then is useful about our VFR metric is the ability to understand maybe the whole vessel in its entirety. Cut points I think are useful, but they don't necessarily translate brilliantly in every situation. And what was really important from the analysis, within the multivariate analysis, actually both MSA and VFR as continuous variables were demonstrably predictive of events. So actually that becomes really important. So I would hope that it will provide operators with a much clearer steer towards whether they've got a good result or bad. But that will hang probably on an interpretation pre and a decision appropriately in terms of treatment. And that is becoming more nuanced. Within physiology, the consideration of pressure pullback gradient or, IFR scout, and looking at where pressure loss may occur and whether actually you're treating focal or diffuse disease, there's a population that we maybe should be avoiding intervention in, even though there's ischemic potential. So I think this all pushes towards a more tailored and patient-focused approach to our treatments, and not this kind of very black and white do or don't.
Thanks, Tom. I think that's a fantastic way to end things. We always want things to be black or white, but there are always many shades of grey. Thank you very much, Tom, for working with us at JACC. It's been an absolute pleasure, and we look forward to seeing the impact of your work as it rolls out. Thanks very much for chatting to us today.
Thanks, Rasha.